Good morning, and welcome to our third annual symposium on valvular heart disease. My name is David Skolnick. We're going to spend the next hour covering this topic of understanding valvular heart disease in 2021. This is my disclosure slide. Before we focus on valvular heart disease, I'd just like to share with you how we have built the cardiovascular program at St. Luke's Health System. I would say that it rests on three main pillars: research, excellence in patient care, and education. And to share with you how this really translates into our valvular heart disease program, it looks like this. We were very early adopters in TAVR, as I'll explain later in the lecture. We started in 2008, the first in Kansas City and one of the first in the country. That allowed us to become early adopters. We became more experienced in the procedure. We then participated in new clinical trials, and after the aortic valve, we moved on to mitral and tricuspid valve disease that you'll see later in the hour. In terms of education, you may know that we have a training program for cardiology fellowship and advanced fellows who are interested in focusing on structural heart disease. That allows us to become better educators. We learn more. We, of course, then recruit the best of our own trainees. And we also have a mission to help educate the community and our patients. And this educational symposium is also part of our mission of educating our colleagues who care for patients with valvular heart disease. And lastly, we're very proud that we are Kansas City's received the only award from the Joint Commission on our program, which allows us to become better in terms of our systems of care and improving our clinical outcomes. One word on the Joint Commission certification that we received several years ago. This is our motto: accuracy in diagnosis and excellence in outcome. Our goal is to reduce the variation in care, improve efficiencies, enhance collaboration, promote a culture of excellence, and of course remain a center for ongoing clinical trials. And ultimately, our mission is to ensure that our community, the community that we serve, has access to highly subspecialized care. And now the overview. We're going to cover the three main common valvular disease that we see in the adult population: severe aortic stenosis, severe mitral regurgitation, and severe tricuspid regurgitation. The picture on the right is a classic illustration from Frank Netter that illustrates the relationship of the aortic, mitral, and tricuspid valves. Under the aortic valve, I'm going to cover this topic about when should we worry, who needs an intervention and when. And we're going to just touch upon, just briefly before you hear other lectures on TAVR, about the role of TAVR, which is transcatheter aortic valve replacement. In the world of mitral valve regurgitation, I want you to understand the essence of the difference between prolapse and functional, which is sometimes called primary and secondary mitral regurgitation, and to understand the role of transcatheter edge-to-edge repair. And then under tricuspid valve regurgitation, we, like the rest of the medical community, will still have a lot to learn. The prevalence of valvular heart disease continues to increase as we get older, and you can see that the inflection increases as we reach the ages of 65 to 75, that's the Medicare population, and as you cross into the seventh decade, the incidence of valvular heart disease really increases a lot. So you can see at aortic valve disease, something like 3 and 4% of the population has significant aortic valve disease, and as much as we talk about TAVR, and we do, there is twice as much mitral disease. This is kind of chapter one of the story. Chapter two is, if you look at the next generation, our population is getting older. The over 65-year-old is going to double. The over 85 population is going to triple. The incidence of valve disease and what we can offer our patients is continue to grow. So how do we make the diagnosis of valvular heart disease? Often patients will come to us with these symptoms of shortness of breath, fatigue, swelling, occasionally chest pain, but not that often. And you can see those first three symptoms cover a lot of sins. They cover a lot of symptoms. They don't just jump out to say, I got valve disease. The physical exam is important. This is an illustration from Norman Rockwell. Auscultation is important. And probably the students in medical school will be using more likely a portable ultrasound scanner. That this technology exists. You can plug into your your iPhone or your Android phone and get a bedside ultrasound image. We still use state-of-the-art echocardiography, so this is a short-axis view of the left ventricle showing how well the heart pumps, and this is normal LV function. This is an example of looking at the direction of regurgitation, and the yellow band represents severe mitral regurgitation. This is relatively new technology that we've had for the last maybe 4 or 5 years easily, using three-dimensional echo to have a much better nuanced understanding of pathology. The arrow points to a prolapse. of the posterior leaflet, and then the spectral Doppler to give us an idea of pressure and gradients within the ventricle. Our goals of care for patients who have valve disease goes like this. Let's first use an analogy of a pacemaker. If you have a patient as a pacemaker, it is our job to follow them over time. We do not want them to present to the emergency department with a pacemaker that's end of life. There's a finite amount of electricity in that battery, and we should follow them along and change their battery electively. The same thing holds true for patients with valvular heart disease. We want patients to undergo timely intervention to ensure that heart function remains normal and to enhance both quality and quantity of life. For those of you like a picture, it looks like this. If you have significant valvular heart disease, over the initial period of time, you'll have little to no symptoms and you will be stable. But we know what this ski slope looks like. This is the natural history of valvular heart disease, and it behooves us to take care of you at this inflection point. We'd rather not take care of you as you're halfway down the hill, and we should have a process to try and make sure that we take care of you earlier in the natural history of the disease. That's our mission. It turns out the management of valvular heart disease has gotten more and more complicated over the last decade. This is what the American College of Cardiology says we should think about aortic stenosis. This is just severe aortic stenosis. The left-hand panel are those patients who are asymptomatic. The right-hand panel are those with symptomatic aortic stenosis. There are a myriad of subdivisions within aortic stenosis. It's not just one diagnosis anymore. It's even more complicated for mitral disease. I'm not going to go through all those little nuances, but at the bottom it says you should go to a valve center of excellence for if you have significant mitral valve disease. And at the end, it encapsulates the ACC statement with the following. The management of patients with complex severe valvular heart disease is best achieved by a heart team at a valve center of excellence, which we have built over the last decade or so at St. Luke's Health System. I want to share with you, if I might digress for just a moment, this book I read 2 years ago by Thomas Friedman, who I think is clever and brilliant. He's an editorialist at the New York Times, and he goes like this. This is a graph from his book. He says that over time, humans have become more adaptable. We've become more nimble in accumulating more information and incorporating it into our daily lives. That line is linear and moving upwards in the right direction, as you would hope we will have achieved over time. This is what an exponential curve looks like. It starts off slowly and then rises very quickly, and this is the curve of technology. Now, Friedman goes on to say that if you go back 1,000 years to like the 11th century, you needed 200 years to slide by before you could appreciate any meaningful change in technology. In the early 21st century, which is kind of where we sit now, Facebook didn't exist, Twitter was still a sound, the cloud was still in the sky, and 4G was a parking spot. And today, we sit here. In other words, technology is moving faster and faster than what we can easily get our hands around. He thinks that artificial intelligence will help us bridge this divide. I show you this slide as a background as we now talk about aortic stenosis as the speed of technology, just to help to set the stage as how fast this technology has moved. There's a physician by the name of Botanus, a French physician in the late 1600s, who's credited with discovering and publishing the first patient who had severe aortic stenosis and died from calcific aortic stenosis. It took about 300 years from the time of that publication until Dr. Starr and his engineer friend Edwards came up with the first mechanical solution for a mechanical valve. This was the Cajun ball valve implanted in 1960. There was a French physician named Alain Carpentier who came up with a tissue valve. Another French surgeon named Alain Crébier who came up with this idea of TAVR, which the idea was unbelievable that in 2002 we could replace an aortic valve with a catheter without opening the chest. This gave rise to TAVR. We're very proud to have been the first in Kansas City, as I mentioned earlier, one of the first in the country to participate in TAVR. And TAVR stands for transcatheter aortic valve replacement. The FDA approved the first clinical trial in 2011, and then shortly thereafter, a series of other indications for TAVR. You can see how fast this timeline has moved, and these are the 9 clinical trials that we participated in this decade. Just to kind of, as a point of reference, just to remind you, in 2007, which is when the first iPhone came around. So just think about how much iPhone technology has changed in the internet. Valve technology has followed that path and continues to move at a very fast pace. So The reason why we are so focused about patients who have symptoms associated with their severe aortic stenosis is that symptomatic severe AS is a lethal disease. So first question, well, I know this is a virtual presentation. I just want you to think about this in your mind. So question 1. What is the 1-year mortality? 1-year mortality for patients with untreated severe aortic stenosis who present with significant heart failure. So basically the question is, what's the natural history if we have severe AS, heart failure, and left untreated? What does that look like at 1 year? Well, it turns out we participated in this landmark trial, which was the Partner 1 trial. These were patients who were randomized with this condition. You can see at the bottom, these were older folks in their 80s, normal LV function, bad heart failure, and severe aortic stenosis, left untreated with standard of care, which is basically diuretics and treating blood pressure. There was a 50% 1-year mortality. With TAVR, reduction was down to 30%. Now, 30% is still a high number. These patients were old and these patients were ill, but there are not a lot of things in cardiology that has an all-cause mortality reduction of 20% in 1 year. This helped launch TAVR for clinical use. I want to kind of share with you how we think about TAVR in terms of echo and how we make this diagnosis. So the first picture is what a normal aortic valve looks like. There's a normal aortic valve open. And if you take Doppler and echo and you look at flow across an aortic valve, a normal aortic valve, I want you to think of that like a garden hose. No nozzle, you turn on the water, and water as it just flows out of the valve, that's 1 meter per second. That's a normal flow through an aortic valve. If you now put your thumb at the end of the garden hose, that spray will go across the backyard, hit the back fence, and if your valve gets really, really small, as a picture in the upper right-hand corner, you see the velocity as it crosses that relatively small orifice is now over 4 meters per second. So in general, velocity of over 4 meters per second, as we measure in the echo lab, you should think about this is thumb on the garden hose, that's severe aortic stenosis. And this is an old paper that basically shows you the timeline in years on the bottom and event-free survival. So most of those events were aortic valve replacement, going to surgery in the old days. Some of those patients died from the aortic stenosis. And you can see that if you have a gradient of a velocity of more than 4 meters per second, almost everybody, 75% or so, will reach that endpoint at 2 years. So we have typically said, once you cross 4 meters, you at least have severe aortic stenosis, and now is the time to figure out when to intervene and replace the valve. I want you to understand that severe aortic stenosis really comes in 3 large categories. I'm going to walk through these categories. The definition of aortic stenosis, as I mentioned, a peak velocity of more than 4 meters, mean gradient of 40 millimeters of mercury, and a valve area of under 1 square centimeter. Those are our working diagnoses by the echo lab. So the first one we talked about, thumb on the garden hose, normal LV function, a high gradient 4 meters, you get a mean gradient of 4 millimeters of mercury, that's severe aortic stenosis. There's this other entity called low flow, low gradient aortic stenosis. You have severe aortic stenosis, we know that, but as we measure the mean gradient, it's only 25 millimeters of mercury. So how does 25 millimeters of mercury translate into severe aortic stenosis? Well, as the picture illustrates, there isn't that much flow going across the valve. If you're stepping on the garden hose, you may still have a very, very small valve. You don't have that much flow because your ejection fraction is reduced. If you want to take the extreme example, just to make the point, if you have critical aortic stenosis and cardiac standstill, no flow, no gradient, but you still have severe aortic stenosis. So these are often patients with a reduced ejection fraction, and I'll explain to you how we figure this out, how we make them with this, label them as this diagnosis of severe aortic stenosis. And then the last category, something relatively new, probably in the last 5 to 7 years, and it's harder to get our hands around this idea. We call it paradoxical low gradient severe aortic stenosis. And here's the paradox. The paradox is that LV function is normal. So if LV function is normal, you're expecting picture 1, where you would have a high gradient. The paradox is that you have normal LV function and the gradient is low. So how do we understand that? Well, it turns out that normal ejection fraction doesn't mean normal stroke volume. The picture on the right, now we're looking at picture 3, the picture on the left, you have a normal cavity. Normal cavity, when that cavity squeezes, you can generate a lot of stroke volume and a lot of flow across the aortic valve. If you have a small cavity, because you're a small person with left ventricular hypertrophy. Your cavity is small. You can still have severe aortic stenosis, but you have relatively little volume to squeeze across that valve. Your gradient will be small. That's the paradox. So let me just walk you through flows. If we look here at normal flow, that's the line that you see in the middle going up and down at 250 mils per second, about a mean gradient of 40, that crosses the red dotted line. That's a valve area of 1 square centimeters. If you now have a fall in your flow because your ejection fraction is low, you had an LAD infarct, you developed a cardiomyopathy, you might now only have a 20 millimeter gradient. So how do we know if you really have severe aortic stenosis? Ordinarily, 20 millimeters of mercury doesn't cross the threshold for severe aortic stenosis because your valve area might be 1.3 or 1.4, and that's not severe. So in these lower flow states, we'll give you dobutamine, a low-dose dobutamine, to see if we can make your ventricle work harder, more vigorously. Can we increase the gradient to 40? And then we think you have that picture 2 that I showed you on the previous slide. That's the role for dobutamine stress echo, to tease out a low-flow severe aortic stenosis. When I read this editorial now almost 10 years ago, I kind of chuckled and I thought, oh, they made a mistake. Look at this. Aortic stenosis is a complex systemic disease. I thought, no, it's a valve disease. No, I got it wrong. Here's what they want to talk about. Your ventricle is struggling against the stenosis of aortic stenosis, but also these older folks often have hypertension. Hypertension puts a load on the ventricle. So it turns out our patients are older and sicker, and the ventricle, as it struggles, doesn't know if it's having problems because of aortic stenosis or problems from aortic stenosis and hypertension. Our patients also can have coronary disease, so they can have infarction, they can have ischemia, they can have remodeling, and the ventricle struggles. And on top of that, there's a host of other comorbidities that patients come to us in their 70s and 80s with renal disease and COPD and obesity and deconditioning, and they'll say, I'm short of breath, I'm tired, and we're supposed to figure out, is that the aortic stenosis, is it the hypertension, is it the LV dysfunction? It's becoming complicated, as I mentioned earlier in the presentation. So when do we intervene? So Eugene Brunwald, probably the grandfather of modern cardiology, published this thing well over 50 years ago, and he basically taught us that we wait until symptoms. Patients with severe aortic stenosis do relatively well until the symptoms of syncope, angina, heart failure, heart failure being the worst, and then there's this precipitous decline in survival. Now, if you look, his patients were dying in their early 60s. Nobody today is dying of aortic stenosis. In the early 60s, he was dealing with patients who were relatively young, relatively healthy, who either had congenital bicuspid aortic stenosis or rheumatic disease. That's not the population we see. This is embraced in the ACC guidelines, and the guidelines get updated every couple of years. This was just rewritten in December of 2020, and they basically say, if you have symptoms with this severe aortic stenosis, you go get a valve. We can discuss whether it's TAVR or SAVR, which is surgery aortic valve replacement. Symptoms with severe AS gets you a valve. They also remind us, if you have severe aortic stenosis and you follow that black box, now your EF is low, that is a class 1 indication for getting a valve. So if you summarize severe AS, you want to know the ejection fraction, you want to know about symptoms. We're going to talk about symptoms because that's a hallmark of when we send patients to surgery or not, or to TAVR. Before we get to symptoms, I just want to share with you this very interesting study. So this is an idea. This starts off with that after the echo criteria for severe aortic stenosis, aortic valve replacement hinges on, as I mentioned, symptoms and ejection fraction. In this study, everybody got TAVR or SAVR. Everybody had symptomatic severe aortic stenosis. They either got a catheter-based solution or surgical-based solution, and they followed them over time. So everyone has their valve fixed. So stage 0, basically this idea was we should be thinking about staging aortic stenosis like cancer. Stage 1 cancer is localized. You excise cancer, you've cured the patient. Stage 4 is metastatic disease. They need more adjuvant therapy, and their long-term prognosis is poor. We should apply that same concept to aortic stenosis. So if you have severe aortic stenosis in stage 0, the rest of your heart is normal. Stage 1, you now have some LVH, You might have some diastolic dysfunction. Your EF might be falling. By stage 2, you now have left atrial pathology, mitral regurgitation, maybe atrial fibrillation. By stage 3, you're now moving on to the right side. You have pulmonary hypertension, tricuspid regurgitation, and by stage 4, not only have you damaged the left ventricle, the mitral valve, the left atrium, the right ventricle, but now you have RV dysfunction and severe tricuspid regurgitation. You can see how aortic valve disease moves slowly across the cardiac performance. And 1-year survival, remember everyone's getting their valve fixed, 1-year survival gets worse depending upon your stage. So again, our job is to take care of you, not just based on the ejection fraction and your symptoms, but we should look at the rest of your ventricle and make sure that the MR and your right ventricle and your tricuspid regurgitation are not actively decompensating due to untreated severe aortic stenosis. All right, I want to spend the next 2 or 3 slides based on symptoms. Symptoms is the trigger upon which we intervene and fix the valve. This is all based on history. And for those of you who work with me or around with me, what I will typically say is we ask questions when we know the answers, which is why we ask the questions. If you look at the echo, you'll have a pretty good understanding of what the patient's symptoms may or may not be. This is a young woman who I've taken care of for 15 years. If you look at that ejection fraction, it's horrible. Call it whatever you want. It's reduced. Her ejection fraction we measured at 15%. She has done extraordinarily well since she initially presented with cardiogenic shock. No hospitalization. She's on good medical therapy, cardiac resynchronization therapy or biventricular pacing. She's doing well. So she comes in to the office. She sits in front of me. Her husband sits behind her so I can see what the husband is doing. So I ask her, this is what I asked her. I said, how are you doing within the confines of your limited physical activity? Well, she's rather indignant with that question. She says, I'm not limited. I'm busy all day long running errands for my husband and I help him with his work. Okay, surely you must be symptomatic. Let me rephrase that question for you. Can you climb a flight of stairs? Her husband just shakes his head. Can you walk a block outside? He says, barely. So what does she have? She has class 3 plus symptoms, but in her mind, she feels okay. She goes at her own pace, she takes a nap, she rests, but she feels she can go. So you have to calibrate your questions based on what you already know most likely is the answer. Okay, this is an easy example. Let's talk about a couple of patients with aortic stenosis. The American College of Cardiology tells us that AVR hinges on symptoms, and this is what they tell us, right? They're supposed to help us. We read their documents, this is what they say. Interpreting the symptoms or lack thereof is difficult. Well, that wasn't helpful, was it? They go on to say that classic symptoms are late. We don't want to be late, right? And yet the classic symptoms, syncope, angina, heart failure, and yet the early symptoms of reduced exercise tolerance can be from aging. All right, that wasn't helpful. And AS progression is variable and unpredictable. Some people have relatively long duration of being asymptomatic, and some people are fine 1 month, and 3 months later or 6 months later, they fall off the cliff, and I'll show you that. And the onset of symptoms can result in irreversible myocardial damage, which means we miss the boat. So in the end, has the ACC helped us? Don't tell them. This I have not found to be a particularly helpful document. I want to go back to this for one more time. I don't want to lose you in the physics, but I want to show you the following. In this example, if you have a mean gradient of 40 millimeters of mercury in this particular flow rate, that crosses that upward slope, and we're going to say this patient has a valve area of 0.7. So clearly severe aortic stenosis by valve area, 40 millimeters of gradient. There's no doubt this patient has severe aortic stenosis, but we measure this at rest. Patients have symptoms typically with exertion. And the title of the slide is that gradients increase by the cardiac output squared. So if we double the cardiac output, I don't know if patients can really double the cardiac output when they have severe aortic stenosis, but if they can, and they go from a cardiac output of 4 liters up to 8 liters, which is a lot, they're doubling their cardiac output, the gradient goes up 4-fold. That means the gradient across the aortic valve would go up to 160 millimeters of mercury. No wonder they develop symptoms with exertion. Okay? Keep that in mind. We measure at rest, but we ask questions with exertions because the gradients go up by the square of the cardiac output. Okay. Here are a couple asymptomatic patients. Here's a 75-year-old gentleman who walks 2 miles a day, no change in his stamina, and you got to really make sure they're not just slowing down. He says, I'm doing fine. I walk the same 2 miles, the same time. And look at this, his peak velocity is 5.5 meters. I told you 4 was severe. 5.5 is really, 5 is really severe. 5.5 is unbelievably severe. He felt well pre-op. I was having angina just thinking about that. I said, you got to get a new valve. And he comes back and he says, I felt better. And I was a little angry at him. It's not often I'm angry at my patient. I said, that's not fair. You said you felt well before. It's not fair you say I feel better now. He just didn't realize how poorly he was feeling. And I think at this point, we get to have a better understanding of the natural history of the disease, and we get to apply the natural history of the disease to the patient and where they sit in this natural history, and in the arc of the disease. Here's another 75-year-old gentleman who feels well and says, I may be slowing a little bit due to age. His peak velocity is 4.1, so he just barely crosses that threshold. He goes to the gym twice a week for an hour, and I would submit to you that's probably more than a lot of us. So do we say he's fine and come back in 6 months? Or do we say he's slowing down, and how do we tease this out? I think it's fine to trust the patient, but as we've been taught in the past by one of our former presidents, trust but verify, as Reagan taught us. Here's what we should say. You feel fine, I'm going to follow you over time, but walk on our treadmill, let's just see. So he walks on the treadmill, he does 7 mets, that's actually just fine. He stops due to leg weakness and fatigue. Fine. But look at this. His blood pressure drops 30 millimeters of mercury, that's clearly abnormal. His STs drop 3 to 4 millimeters, that's profoundly abnormal. This is clearly an abnormal stress test, and yet he feels relatively well. The American College of Cardiology says it's a 2A indication, which means we should consider it and we should do this. So if you're following patients with little to no symptoms who have severe aortic stenosis, walk them on the treadmill. If they do well, we'll do it again in 6 months. If not in 6 months, definitely a year. If they don't do well, we've unmasked symptoms. And now we should think about valve intervention. And the last story I just want to share with you, this is just a humbling story about how we care for patients and whether we're listening or not listening, what they tell us and how we interpret their symptoms. So this is an 80-year-old woman who reports progressive dyspnea and exertion over the summer of 2016. In November, she comes to clinic, she returns from a trip, and she says as a chief complaint, really, I'm exhausted. That doesn't tell us a whole lot, does it? She struggles with stairs at home due to dyspnea, and we attribute that to this deconditioning, arthritis. And so the real question is she having symptoms from aortic stenosis? Here's her echo. Mean gradient is 43. The valve error is small, so there's no doubt she has severe aortic stenosis. Here's her ejection fraction. Great looking ventricle. We have the diagnosis. The question is, are her symptoms attributed to the valve or not? We said we thought she was asymptomatic. These symptoms didn't really jump out at us. We said, call if you have angina. That's what we're worried about, is angina. So 2 months later, she's now dyspneic room to room. All right, we would probably now call that heart failure or LV dysfunction. 2 days after heartburn, that's really angina. She comes to the emergency department, and this is what her ejection fraction looks like. All right, this is a profound reduction in just 2 months. In retrospect, she was probably having symptoms in November. In retrospect, she was probably having symptoms 6 months earlier. We either didn't see her or we didn't sort it out. She didn't walk on the treadmill. She was too sick for discharge, and 12 days later, that's a long hospitalization, she got inpatient TAVR. We really try and send most of our patients home for TAVR, or surgery. Some patients occasionally are just too sick. So here's an example of somebody who really deteriorated relatively quickly. The natural history, why do we worry so much about hospitalization for heart failure? It's just a bad prognostic marker. Here's what the natural history looks like. The bottom line is time. The y-axis is LV function or ventricular performance. And you can see after each episode of decompensated heart failure, even though the patient says, I feel well, I'm back to doing what I'm doing, the ventricle, either at the ventricular level or the myocyte level, is never really back to where it started from. There's some gradual decline, fibrosis, remodeling. So we should really try and avoid decompensated heart failure prompting hospitalization. And just to drive the point home, this is a study looking at about 100 patients with normal LV function and no symptoms in beginning with severe aortic stenosis. And if they go and have surgery, this was a surgical population, The green line shows this is survival after surgery if they had surgery before they had class 3 heart failure, so relatively healthy patients. If they stumbled into the hospital and had decompensated heart failure, their long-term prognosis, even after valve replacement, is not good. The message is we want to fix these valves before they have decompensated heart failure. All right. And at the end of the day, you should understand that TAVR is ultimately life-saving. So this is the transesophageal echo. The arrow is pointing at a perfectly normal aortic valve. There are some labels for those of you who aren't used to looking at echo. The left atrium is at the top, the left ventricle is at the bottom left, and the aorta is just above the aortic valve. This is what severe aortic stenosis looks like, a heavily calcified valve that barely opens. TAVR is this concept where you take a catheter. Often we start it in the common femoral artery, head north around the arch. There are a variety of ways of deploying the valve. In this particular example, it's the balloon expanded. You expand the balloon, you expand the stent. When you take down the balloon, a brand new valve is housed within that stent, and you can barely see the frame of the stent that basically takes the old valve and smashes it against the wall, and you deflate the balloon and withdraw the catheter. You're left with a brand new aortic valve, looks strikingly similar to the one that we were born with. And this is what has happened over time in our country. Since 2012, when FDA first approved TAVR, over 4 years, the increase of TAVR volume has just grown almost exponential. So in 2012, we took care in this country, about 33,000 patients got aortic valve intervention. The vast, vast majority of that was surgery. 4 years later, we have now doubled the number of patients who have access to TAVR. They're patients who are typically older, frailer, who would not have been candidates for surgery. Net, there are just more patients benefiting from this intervention, and more patients are living longer as we treat symptomatic severe aortic stenosis. Okay, we're now going to move on to mitral valve disease. This is a schematic showing a simple understanding of the mitral valve. The cartoon on the left shows the left atrium at the top, the mitral valve is open, and the left ventricle is in the bottom. And the corresponding image on the right is the transesophageal echo showing the mitral and aortic valve opening and closing. Here is with color Doppler. The transducer is at the top of the triangle, and the convention with color Doppler is blue away. So blue is leaving the left atrium, entering the left ventricle. The valve closes, red towards the probe, so blood is now moving towards the aortic valve. So blue away, red towards, and this is how blood flows and enters the left ventricle. This is a simplistic understanding of the mitral valve. It turns out it's just a little bit more complicated. So when blood enters the left ventricle, this is the anterior leaflet that you see on the right-hand side of the screen. When the mitral valve opens, blood doesn't go straight into the ventricle. It actually enters like a vortex, like the torquing, spinning view you have of a tornado. The blood enters the left ventricle, it hits the apex, it spins around and goes out towards the left ventricular outflow tract, towards the aortic valve. It actually begins to close the aortic valve all before systole starts. This is a zoomed-in view of the classic Frank Netter illustration of the heart. I just want to illustrate that there are really 4 parts to think about with the mitral valve to have a competent mitral valve. You obviously have the leaflets. There's the anterior leaflet and the posterior leaflets. You have an annulus that we'll talk about. That's the ring around the valve. That's important. You have cords that attach it to the papillary muscles. And the last thing that needs to have a competent valve is a normal functioning ventricle. And we'll talk about the ventricle in a minute. So you have an annulus, you have leaflets, you have cords and papillary muscles, and then the ventricle. The mitral valve is not a pancake. It isn't just shutters on a door. It is a 3-dimensional structure. It's often described as saddle shape. The blue band is the 3-dimensional structure of the mitral annulus. The leaflets are then layered and folded into the annulus. And when the mitral valve closes, there are really 3 motions. There's a little bit of a sphincter action where the posterior annulus actually gets smaller. There's a hinging effect that actually makes the orifice smaller. And the picture on the bottom shows that when the ventricle contracts, the mitral valve moves in unison with the ventricle. And then the ventricle is doing 3 things. First and foremost, the ventricle is a piston. It pumps from the base down to the apex. So there's a piston effect. There's a squeezing effect that shows the middle picture, and then there's torquing. So the ventricle, piston, squeeze, torque. The mitral valve has a hinging effect, and it closes on the posterior annulus and moves with the ventricle. All these things work in concert to have a competent mitral valve. The picture on the left is a surgeon's view. The aortic valve is always at the top. We see the anterior leaflet and the posterior leaflet. The posterior leaflet really has 3 scallops that we call P1, P2, P3. The anterior leaflet is really much larger and doesn't have scallops, but we label them as if they have scallops so we have some way of communicating where the pathology is. And the other 2 pictures are from an animal lab where there's a flow bath and a camera. So the picture in the middle is looking from the left atrium down, which is how the surgeon sees it, which is how we typically see it on transesophageal echo. The picture on the far right, we see on echo. The surgeon never will see this view, but what I want you to see, the anterior leaflet is up top. Obviously, the posterior leaflet is on the bottom. If you look up, the aortic valve is opening at the very, very top of the frame. But I want you to appreciate really the complexity and the jungle of cords of the subvalvular apparatus and how complicated it is. And it's really humbling to realize how they can repair these valves with all these cords in place. What you should understand for mitral valve disease, this slide and the next slide, is that it is a progressive disease. The tagline is, if it's left untreated, mitral regurgitation can lead to both heart failure and death. And the circle is that you get mitral regurgitation, you get increased wall stress, you can get muscle damage, you get LV dysfunction, your ventricle dilates, then you get more mitral regurgitation, and this thing goes round and around. And along the way, when the mitral regurgitation is severe enough, it's time to intervene and fix the mitral valve. We're going to go through these 2 kind of classifications for mitral valve disease. You need to understand that mitral valve disease comes in really 2 sorts. There's primary, which is basically prolapse, where you have a valvular pathology, and you have secondary mitral regurgitation, where the problem is the ventricle. There's nothing wrong with the valve. The ventricle is enlarged, pulls on the mitral valve, and now the valve can't close. The picture on the left shows you that over time, if you have severe mitral regurgitation, which we now measure by effective regurgitant orifice, how big is the hole? So 40 square millimeters is a big hole. That's severe mitral regurgitation on both slides. If you have severe mitral regurgitation with prolapse, over time you do relatively poorly left untreated with a decline in survival, not so good over 4 or 5 years. If you have secondary MR, which means you have a ventricular problem, not a valvular problem, your ventricle is enlarged, your leaflets can't coapt anymore, they close like this, not like that. If you have severe mitral regurgitation, your prognosis is poor. Your prognosis is poor for mild MR, I should tell you. It's just even worse with moderate and severe. I don't want to spend a lot of time, but I do want to kind of walk you through the idea that Alain Carpentier, the French surgeon, came up with this classification just to help us understand the kinds of pathology that exist. So if you have primary mitral valve disease, in our country, for the most part, that is prolapse, highlighted in yellow. You can, of course, have radiation disease. You can have rheumatic disease. It's just not that common. So just to give you an example, when you have radiation disease, the cords that normally extend from the valve into the ventricles are completely tethered and shrunken up, and so your leaflets can't really move and they get stuck into the ventricle. We don't see it that often. We think of prolapse as what we see day in, day out. And so this schematic shows you that at one end you can have simple P2 prolapse where you just have, let's say, a torn cord and one leaflet is flopping backwards. I'll show you a picture like that. And as mitral valve becomes more extensive, you get more extensive pathology involving the posterior leaflet. It then involves almost the entire valve. And at the far end, we call that Barlow's valve, where you have diffuse myxomative changes involving both the anterior and the posterior leaflet. And on top of that, some patients have other disease, even with prolapse. They can have focal calcification. They can have what we call MAC, which is mitral annular calcification, which the surgeons hate to operate because it's hard to suture through calcification. The annulus can dilate, and you can see these patients can present with a variety of pathology. That's primary disease. Secondary disease, really, when we say secondary or functional MR on an echo report, what you need to understand, there's nothing wrong with the valve. You can see these 2 pictures down here, and I'll show you others. The ventricle just gets enlarged, the leaflets can't coapt, and the valve leaks. You get this circle. You get LV remodeling, let's say from an infarct or a non-ischemic cardiomyopathy. Your volume increases. You get mitral regurgitation. You get increased load on your ventricle. This just goes round and round. It's a vicious circle for which patients long-term do not do well. I'm going to touch upon this idea, which is proportionate and disproportionate mitral regurgitation. It's a new concept. You may see it. It's not easy to get your hands around, but I do want to touch upon it. And the last thing about functional MR is it can be load dependent and very dynamic. You diurese the patient, you treat the hypertension, maybe you restore sinus rhythm, you revascularize the ventricle. Sometimes patients can go from significant mitral regurgitation with a bad ventricle. If the ventricle gets better, the mitral regurgitation in some patients can get remarkably better. And then there's a relatively new entity that we've come to understand called atrial functional mitral regurgitation. There's nothing wrong with the ventricle. There's nothing wrong with the valve. It's just the left atrium, maybe from chronic atrial fibrillation or chronic hypertension. The left atrium now gets big, enlarges the annulus, and you can get mitral regurgitation. I just want to touch upon this idea of functional mitral regurgitation. Is it a biomarker or a therapeutic target? So let's start with an easy example. We see patients with PVCs all the time. When you see PVCs, the question is, are PVCs simply a marker because they have a bad ventricle? Not uncommon with patients who have non-ischemic cardiomyopathies, an EF of 25%, a little heart failure, you'll see PVCs, and the PVCs are the marker of the cardiomyopathy. Treating the PVCs will not address and fix the ventricle. You have a ventricular problem. On the other hand, there are some patients who have what we call a PVC-induced cardiomyopathy. These are patients who have 15 or maybe 20% PVC burden. It's the PVCs that are driving and causing the cardiomyopathy. You ablate the PVC focus and you cure the cardiomyopathy. Figuring out which of these two entities isn't always so easy, but it's important to make that diagnosis. All right, hopefully that's a relatively easier concept to understand as we now move to the mitral regurgitation story because it follows the same pattern. It goes like this. I'm going to read the slide. In many patients, mitral regurgitation reflects the severity of the underlying LV disease, which is the primary determinant for disability and death. If you have a bad ventricle, that's what's driving heart failure and death. That is, the mitral regurgitation is simply a biomarker for a bad ventricular myopathy, just like the PVCs are a marker for your LV dysfunction. It's the LV that drives the MR, and if you fix the MR, you're still left with a bad ventricle. You haven't really helped the patient. On the other hand, there are patients who have functional MR that is the primary factor for the hemodynamic stress on the ventricle. And if you fix the MR, that will alter the clinical course and the prognosis. And figuring out which two these patients have, just like with the PVCs, isn't always so easy. So in 2021, what does mitral regurgitation look like? Three-dimensional echo, mitral valve prolapse, that white arrow, yellow arrow, is pointing to a flail segment with a torn cord. Hopefully you can appreciate there. And basically, we have gone from 2D imaging to transesophageal echo, now to 3D imaging. We understand the mechanism of MR, and the American Society of Echo asks us to be much more precise and to really quantify the degree of mitral regurgitation. Here's an example of mitral valve prolapse, again on transesophageal echo. The blue arrow is the normal anterior leaflets that's held in place. The yellow arrow is the prolapsing segment into the left atrium. Hopefully you can see the little cord that should have been tethered in the left ventricle holding the valve in place. And what you should know that there's no role for medical therapy for severe mitral regurgitation. These patients are asymptomatic for a period of time, and when they develop symptoms, we have missed the sweet spot for fixing the valve. We do not treat them with medicines. This is functional MR. You can see the gap in those two leaflets. This is a ventricular problem. There's the gap. There's nothing wrong with that valve. The leaflets have just been stretched apart because the ventricle has dilated. This we call secondary or functional mitral regurgitation. There's no role for surgery or replacement for most patients. This has been well studied. The surgical intervention, the surgical indication for these patients is relatively small. We treat the ventricle, afterload reduction, diuresis, revascularization, biventricular pacing, and then mitral clip, or edge-to-edge repair as we now call it. So there's a catheter that we have gone from the vein into the right atrium. We have crossed the intra-atrial septum. We're now in the left ventricle. We're opening the device and ready to deploy the device once we cross the valve. And the FDA approved this intervention for patients who are at high risk for degenerative mitral regurgitation. That's a fancy word for prolapse or primary disease. And in 2019 for patients with functional or secondary mitral regurgitation on maximum guideline-directed medical therapy. Okay, let's talk about mitral valve repair that Dr. Davis will talk about in a few lectures. This cartoon I lifted from Tyrone Davis, who's a very famous valve surgeon in Toronto. Oh crap, was that today? The idea is you do not want to miss the boat. Timing is very important for patients with primary mitral valve disease. These patients go to surgery when your EF is still good, when your ventricle is still small, before any symptoms of heart failure. You'd like to go to a high volume center. And as I mentioned earlier, there's no role for medical therapy in the asymptomatic state. We want to send patients to surgery before the ventricle decompensates, before they have any symptoms. And it looks like this. It turns out, don't tell Dr. Davis, it's not that complicated, at least for the simple P2 prolapse. You cut along the dotted line, you sew it back together, and panel D is the closed incision as you have repaired the mitral valve. The myxomatous leaflet is often, not always, the P2 scallop, and it looks like this. So in the upper left-hand corner is the resected wedge. In the upper right-hand corner is the P2 scallop with the torn corn. It's sewn together, and the bottom right-hand corner shows you the annulus. And here is an example of flail P2. I showed you this earlier on the upper left-hand corner. We turn on the color Doppler. This is an eccentric jet of severe mitral regurgitation. This is, again, with three-dimensional echo as we stare down at the mitral valve. It's perhaps hard to see the pathology in the anterior leaflet. If you crop away the anterior leaflet and we stare just at the posterior leaflet, you can see this is a broad-based P2 scallop that prolapses with a series of torn cords. And if you ask kindly and repeatedly, this is the surgical specimen that they occasionally share with you. And so now we have a very good understanding of now what is complex P2 pathology and harder for a good surgical repair. This guy did very, very well with a perfect result here. This last slide I'd like to share with you. This is a study of Medicare patients. So everyone was over 65. The average age you can see was 74 years old, and they looked at nearly 50,000 Medicare patients. Over a 10-year survival, your older patient will do better if they get a repair rather than a replacement. So do not assume just because your patient is older that we should be happy with a replaced valve. If the valve is very myxomatous, it may not be repairable, but we should still always strive for a repair valve. They will do better in the long term. If you see that footnote at the bottom, it said that 60% of these patients had heart failure. That means 60% of patients had a valve intervention too late in the natural history of their disease. In summary, the ACC says that if you have primary mitral valve disease with symptoms, surgical intervention is a class 1 indication. There's no doubt you should go and shoot for mitral valve repair. But if you go down the right-hand slide, if you are too sick or surgery is prohibitive, and you have favorable anatomy, which isn't always a given, transcatheter edge repair is now a solid 2A indication, which is part of what we do typically on Thursdays for mitral TEER. Transcatheter edge-to-edge repair, which is mitral TEER. And here is just some humbling data. Surgical intervention is not always an option, and look at that. Nearly 50% of patients with symptomatic severe mitral regurgitation don't undergo surgery because of low EF, high operative risks, comorbidities, and too old, and that's true for Canada, this country, and Europe. These are common themes, and you can see in this slide in the yellow or orange, these patients do not go to surgery, and the older you get, the more likely you are not to go and have surgery. This brings us to the role of transcatheter edge-to-edge repair, which we call mitral TEER. Here's the left ventricle, severe mitral regurgitation. We start in the common femoral vein, head north in the IVC. We cross the atrial septum in a relatively specific location. We're now in the left atrium. There is the device, at least the one that's FDA approved. The yellow arrows show where both leaflets go into the device. We then close the little grippers, and when we close the device, it looks like this. So we have the device inside the left ventricle. just below the mitral valve. The leaflets are supposed to rest on the two arms. Their grippers come down, and we close the device. So let me just share with you an example of a patient with complex A3P3 disease. This is a 95-year-old gentleman. He has normal LV function. We have followed him for mitral valve prolapse, and he has been stable. He then presents with acute decompensated heart failure. Most likely he tore another cord, had now more severe mitral regurgitation. We were unable to clear his pulmonary edema despite medical therapy. So refractory decompensated heart failure in the hospital. This is what his echo looks like. This is a zoomed up view looking at his mitral valve, his mitral regurgitation. A lot of mitral regurgitation going in a multiple different directions. As we look with three-dimensional echo, staring down at the mitral valve, this arrow here is to highlight it is coming from the corner, and it's going in both the anterior and the posterior direction. I've shown you this picture earlier. Here we have our device opening, and after one device clip, you can see that there is essentially trivial mitral regurgitation. And just to drive home the hemodynamics, in the cath lab, the V wave, which is what the left atrium sees when you have ventricular contraction and severe mitral regurgitation, is 60. His V wave is 60. I mean, yours is probably 10. No wonder he was drowning in mitral regurgitation. After the clip, it got cut in a third. His mean left atrial pressure went from 24 to 16. This is imminently treatable with little diuresis. He continues to do quite well. All right, second question. What is the 2-year mortality for patients with reduced LV function on good medical therapy for heart failure who still have significant functional mitral regurgitation? So according to the guidelines, low EF, good medical therapy for heart failure, and they still have significant mitral regurgitation. All right, think about what that number might be, and we'll get to it. So let's walk through significant mitral regurgitation. Secondary MR. So a normal ventricle and a normal mitral valve, you can see that when the valve collapses, it's not just windows on a shutter. There's actually up to a centimeter of overlap to get a good seal, tethered by these cords, anchored to the posterior to the papillary muscle, which is what the PM stands for. If you infarct, let's just say the lateral wall, which is now the black space, the black wall, that then moves and dilates away from your ventricle. It pulls on the papillary muscle, pulls on the cords. Your mitral valve can't close, and if it closes, it has a gap. Your annulus might dilate, which is the blue arrow. No wonder you get mitral regurgitation. And in these patients, let me read to you these 4 statements. Neither mitral valve repair nor replacement has reduced heart failure or death in functional MR. Basically, we study those patients in clinical trials. There's no role in general for surgery for functional MR. 2, the poor survival for functional MR is independent. So significant functional MR is independent to all these other things that we think are really important for prognosis. EF, age, heart failure, and chronic kidney disease. It trumps all those. And functional MR, as I mentioned earlier, is load dependent and dynamic. So it can get better as we treat heart failure and hypertension. And the last one is that the severity of functional MR should only be established after optimal medical therapy, biventricular pacing or CRT if they need it, and revascularization. In other words, this is typically not a diagnosis we should be making in the hospital, because if they're in the hospital, they're decompensated. We should let them clear their heart failure, optimize the ventricle, and reassess ideally as an outpatient. All right, so that question I asked you about long-term survival and how they do comes from the COAP trial that we participated several years ago, looking at edge-to-edge repair in this heart failure population. Patients who had ejection fraction between 20 and 50, that's a broad range, 3 to 4 plus mitral regurgitation on good medical therapy. You can see they were relatively young, if we think 70s is young. All had class 2 and 3 heart failure, so mild to moderate heart failure, low EF, and big ventricles. A 2-year study, at the end of 2 years, the number needed to treat to prevent 1 hospitalization was 3. You treat 3 patients with this device, you prevent 1 hospitalization. I showed you earlier, having hospitalization heart failure, having a hospitalization for decompensated heart failure is a poor prognosis. You do poorly over time, and we reduce the hospitalization in half at the end of 2 years, and there's a reduction in all-cause mortality. Just like TAVR had a profound all-cause mortality, we cut all-cause mortality at the end of 2 years by 17%. Not quite as strong as TAVR, but very, very robust data. You treat nearly 6 patients, you will survive. 1 patient will survive. So this is what functional mitral regurgitation looks like. Again, I showed you this picture. The valve is normal. The leaflets are pulled apart because the ventricle is dilated. You see that yellow band of severe mitral regurgitation. The picture in the corner in the dotted line shows we're looking through this complex three-dimensional structure where the dotted line looks like. And we're looking at mitral regurgitation on this dot, and you can see that looks like a dot, at least when it crosses the leaflets. If you turn your TE probe 90 degrees and you look in this plane, you can see there's a much larger gap. So when we say functional mitral regurgitation, we will also often be imaging in the upper left-hand panel, but I want you to imagine we might be seeing something as unbelievably broad of this jet of torrential mitral regurgitation. And here's a typical example of a young patient, ischemic cardiomyopathy. He has biventricular pacing. He has mild to moderate heart failure, low EF, and persistent heart failure with 3+ mitral regurgitation. The picture on the bottom shows the mitral regurgitation. You can see this broad-based jet in between those 2 arrows. There we are taking our device. You can see the posterior leaflet is resting on the arm. The anterior leaflet is slipping off, so we have to adjust that. There it is. The blue arrow shows we need a little adjustment because that's slipping off the arm of the device. There it is, one device clip right down the middle with relatively mild, there it is, with the yellow arrow, relatively mild mitral regurgitation. That's the red flame. The blue is blood entering the left ventricle. The red flame on the kind of at 4 o'clock on that short axis view, if you will, is the regurgitant jet. I'd like to transition now to the last valve, severe tricuspid regurgitation. Most people who talk on this topic have this tagline, forgotten but important. Here's a paper that came out 1.5 years ago titled, Tricuspid Regurgitation is a Public Health Crisis. Well, we certainly have a lot of crises in healthcare. It's hard to imagine tricuspid regurgitation is one of them, but the point they wanted to make is the following. The outcomes from this valvular lesion is poor. We often intervene late, often way late in the natural history. We have no reliable risk scoring as we have for the mitral and the aortic valve, as I talked about. The pathology is complex. A fair number of patients will have significant tricuspid regurgitation after a surgical repair, and we really have little clinical trial data to help guide which patients, which procedures to help take care of these patients. So one more question for you to ponder. Question 3. Just like typical harsh murmur of severe aortic stenosis or the blowing murmur of severe mitral regurgitation, the diagnosis of severe tricuspid regurgitation is easily made on auscultation. Can we hear this lesion just as easily as we can hear severe AS and severe MR? Does that answer yes or no? I'll get to the answer in a minute. The picture on the left shows you, once again, this is a very complex structure, again described as a saddle-shaped structure. It is non-planar. The next 2 pictures, the picture in the middle shows you a view looking from the right atrium down at the tricuspid valve. You should appreciate how thin and translucent these valves are. And the picture on the far right is a side view, again looking at the complex subvalvular apparatus with a lot of papillary muscles and chordal strands, making both repair and catheter-based intervention challenging. I want to share with you one patient story. This pertains to the question. So Bob is a 64-year-old. He has prior mechanical aortic valve replacement and a mitral annuloplasty, an ICD, and hypertension. So he has left-sided disease, hypertension, and ICD. He now presents with mild edema for a couple of weeks. He does not have P&D. He does not have orthopnea. He is a little vague about how much and how often he takes his Lasix 20 milligrams, which, as you know, is not a big dose. His blood pressure is normal. He has a little bit of jugular venous dissension, a very soft systolic murmur, which doesn't really help me, truth be told. He has a mechanical valve. He's had mitral valve disease. He has 2+ edema, so he has what he says he has. He has a little edema. So my impression in clinic, this is a patient I took care of, mild volume overload. It's almost always left-sided disease, almost either mild systolic or diastolic heart failure. Recommend a little more Lasix. This is a very common clinical scenario, and they almost always get better with diuresis. And in my mind, I don't think I wrote this in the notes, here's the common way we think about. We, one, blame the patient, either too much salt or maybe a little non-compliant with his Lasix. Maybe it's the dreaded amlodipine that can cause edema. Not often, but it's an easy maybe. Or could it be the dreaded diastolic heart failure that can be a common explanation for patients who are older with hypertension who has valvular heart disease? Sure. Well, 2 months later, he's admitted for a 20-pound weight gain, pitting edema to his thighs. His echo shows severe tricuspid regurgitation, a dilated RV with reduced systolic function. Likely, he had some of this pathology 2 months earlier when I saw him, and I could not appreciate it. And here is why. Why is the diagnosis so hard for severe tricuspid regurgitation? Well, again, as I mentioned earlier, their symptoms are dyspnea, fatigue, swelling. That doesn't jump out to say tricuspid regurgitation. It doesn't even jump out to say valve disease, maybe. And at times, these patients will have no symptoms. We listen. But as this picture really illustrates, the murmur is often soft, sometimes even absent, even with severe tricuspid regurgitation. You can have severe TR and barely have an audible murmur. Why? Well, we look at the echo, and if we look at the echo, the color jet is turbulence. So you saw with mitral regurgitation, there were a lot of colors. With the aortic stenosis, thumb on the garden hose, a lot of turbulence. This is laminar flow. You just see a nice steady blue flame during systole. Laminar flow is right there with the arrows. It doesn't cause any noise. So the murmur is soft, if not absent. It's like a garden hose with no thumb at the end, soft, right? We don't have this analogy, and we certainly do not have this analogy. The murmur is soft. We may not hear it. And if you look at the prevalence of significant tricuspid regurgitation, it is increasing as we get older, and it is almost always associated with left-sided disease. If you look at this pie chart, the green, 50% of patients with significant TR have left-sided valve disease, aortic disease, and mitral disease. 13% will have LV dysfunction. So well over half have left-sided disease, occasionally pulmonary hypertension, but we don't see a lot of isolated pulmonary hypertension. So think left-sided disease. Large paper with a large number of patients from the Mayo Clinic, 11,000 patients you can see with either little to no heart failure symptoms. And you can see that as you go from trivial tricuspid regurgitation at the top to severe tricuspid regurgitation at the bottom, your long-term survival with medical therapy alone is poor. And in the yellow box, it basically says severe TR is a poor prognostic marker, independent of a lot of other things that help predict how patients will do over time. So this is not a valvular lesion we should ignore. What's the mechanism of TR? Most of the time, it's secondary. Most of the time, it's not a primary valve disease. We don't really see radiation or prolapse or Epstein's. It's not a primary valve disease. It's a ventricular disease. Most of these patients have annular dilatation, tethering of the leaflets inside the right ventricle as the right ventricle dilates and remodels. And if you look at the very bottom, 40% of these patients have significant mitral disease. A quarter have significant aortic stenosis. So here's a patient, if we look just at the right side, right ventricle at the top, right atrium at the bottom, and you have a lot of tricuspid regurgitation. Now, sometimes we think, look at that line. That line's a pacemaker wire or an ICD wire. And so we say, well, maybe the wire is somehow intervening with leaflet coaptation. That answer is maybe. That answer is often more no than yes, but we wonder. What you should look at, as I mentioned earlier, is what you see here in the middle of the slide. Don't focus on the right side. Look at the left side. What do we see on the left side? Unbelievable torrential mitral regurgitation, LV dysfunction. No wonder they have tricuspid regurgitation. It's a marker for left-sided disease. By far and away, the most common thing, left-sided disease. How do we take care of tricuspid regurgitation? This is what the ACC basically says. You got a leaky valve, we treat them with diuretics. That's where we start. Diuretics, when it leaks more or less they say, more diuretics. And when it leaks so much that you have basically flooded the basement, or patients now have edema and ascites and profound right-sided heart failure, They say likely too late for tricuspid valve intervention. The idea is there's a very narrow sweet spot for tricuspid valve intervention. We do send patients occasionally to surgery, but finding that sweet spot is very, very hard, which is why catheter-based interventions will likely be a viable option, which is currently being studied. If you look here at this chart, and we'll start in the third column, in the third box. If you have what they label as stage 3, these patients have no symptoms or vague symptoms in the setting of severe tricuspid regurgitation. They might have some symptoms of dyspnea, some degree of shortness of breath because they can't preload the left side, but these are subtle, vague symptoms at all. We start with diuresis. We start with diuresis if they have edema. These early stage patients are very sensitive to both preload and afterload, so fix the ventricle, treat the hypertension, shoot what you can do on the left side, diurese them, decrease their preload, and these patients often will respond to medical therapy. As the disease marches along, you can see now the picture on the upper chart, you're now getting ventricular dilatation, remodeling the ventricle. The leaflets are tethering the valve inside the ventricle. The leaflets can't co-op. You're going to get right-sided heart failure, a low output state, which means they get early satiety. They get bloated and fill up easily. They're short of breath. Their stamina is going down with or without edema. They don't come in with big symptoms. You got to really kind of drag it out of them to know whether they're really having symptoms of right-sided heart failure. And typically, it's more diuretics. If you're lucky and you find them in the sweet spot, you might send them to surgery. And if we wait a little longer, let me go back one thing. At the very top it says, compensatory mechanisms are less lasting in the RV than the LV. The RV doesn't tolerate this very long, and left out untreated, they now will have profound right-sided heart failure, torrential tricuspid regurgitation, and they are anywhere close to being a candidate for surgical intervention. So just to kind of give you a patient example, a new patient to our practice, their former cardiologist retired, and here's the story. A 75-year-old woman, long history of atrial fibrillation, so likely big atria. The prior echo showed 3+ TE, 3+ tricuspid regurgitation. I'm already clued into the idea that we may be dealing with right-sided disease, and we're here to try and look for some symptoms. She has early satiety, which means she fills up easily because her literally the stomach or liver is congested with fluid. She has worsening edema and only on a relatively modest dose of diuretics. She has pulsatile neck veins, a pulsatile liver, and edema. I will tell you, it is rare to find this constellation of physical findings with severe TR. I've taken care of a lot of patients with severe TR, screened them with transesophageal echo for our clinical trials. It is not common they have this exam that really kind of jumps out. She did. There's her tricuspid regurgitation, a fair amount of tricuspid regurgitation. We called it severe with moderate RV dysfunction. She got her valve replaced, surgically replaced. We fixed the mitral valve because it too needed to be reduce the regurgitation. And within a couple months when she recovered from surgery, she feels better, her edema is gone, her exercise tolerance has improved, her neck vein is flat, or neck veins are flat. So we can clearly make these patients feel better. This is an example of a dilated right ventricle. Those arrows are pointing to, I don't know how well they show up on the slide, but leaflets that are really very, very far spaced apart. The yellow band shows torrential tricuspid regurgitation. The picture on the far right is a three-dimensional echo that when it plays, that black space, that triangular black space is the gap when the leaflets are supposed to be touching, really profound malcoaptation. And over the years, we have lived with mild, moderate, and severe tricuspid regurgitation. Over the last year or two, as the transcatheter clinical trials have been starting, we're taking care of patients with more and more tricuspid regurgitation. Now they have this new category of massive and torrential. These are terms that are real terms, not just to be inflammatory, but you can see these are patients whose annulus and valve areas have just gotten bigger and bigger and bigger. These are the clinical trials that are being studied around in this country and in Europe. We are doing the two in the dotted box in the upper right and the one on the bottom. The upper right is CLASP TR that we have been doing for the last couple of months. The one on the bottom we should be starting soon. So in summary, if I should ask you to remember just a handful of ideas, symptomatic severe aortic stenosis carries a very poor prognosis left untreated. Assessing whether an AS patient is symptomatic is challenging. It hinges on history. I'd suggest that we work carefully on the history and when in doubt, put them on the treadmill. For the mitral world, it's important to distinguish between primary, which is basically prolapse, and secondary, which means you have a ventricular problem. The prognosis is different and the management is different. For patients with secondary mitral regurgitation, consider transcatheter edge-to-edge repair for those patients who have persistent heart failure on good medical therapy for their heart failure who still have symptoms. And for the tricuspid conclusions, functional TR has a poor prognosis independent of LV function and RV function. And functional TR is a silent yet progressive disease. You might get lucky and find JVD and RV heave, edema, likely, but not often will you see all three. Look for symptoms of dyspnea, early satiety, and consider enrollment in our clinical trials here at St. Luke's Health System. Thank you.